Good evening, everybody. I'm Josh Goodwin. I'm the doctor at Regenexx Las Vegas. I'll be going through the webinar tonight. As I said, my name is Josh Goodwin. I'm the doctor at Regenexx Las Vegas. Just want to give a brief overview of what's going to be covered and the formats of the webinar. So as you can see on the screen, we're going to mainly be talking about some of the different options we provide at our clinic for spine conditions. We'll give just an overview, obviously, of myself, who I am, what my background is, a history of what Regenexx is and where that came from, some basic information just about spinal structure, different conditions, current treatments that maybe people would be familiar with, and then go into more detail about our specific approach to dealing with spinal conditions, how we evaluate patients, how we determine who is a good candidate or not a good candidate for procedures, so people get a sense of what the process is with making recommendations for different intervention. And then at the end, we'll spend a little time just for a question and answer. You can jot down questions in the Q&A or the chat section so that I can see them. I'll likely not stop during the webinar to answer them unless they're very relevant to what I'm talking about. But at the end, I'll make sure I go through all of them. So feel free to jot them down before you forget. Hopefully we can go through this smoothly and quickly. There's kind of a lot of information, so we'll try to just get through some of it. Hopefully you guys will learn something that you can take with you to think about, and maybe give you some different options for dealing with low back pain. We also treat all orthopedic conditions, so all orthopedic joints. So some of this does apply to other areas, but we're going to mainly be focusing on spinal conditions. But a lot of the background of who I am, what we do, the approach, it can is also useful for other orthopedic conditions outside the spine. So just a little bit about my background. So I did go to medical school at the University of New Mexico, where I grew up. So I'm a medical doctor. I did my residency in a physical medicine and rehabilitation in Texas. That's a non-surgical specialty focusing on, trying to help people restore function as best they can, despite injury or orthopedic injuries or other types of traumatic injury. I am board certified. I'm fellowship trained in sports medicine and interventional spine. I've been performing kind of these regenerative based procedures since 2014. I've been with Regenexx since 2015. So coming up on 9 years with Regenexx and a decade of performing different regenerative based therapies for orthopedic conditions. So that's a little bit about my background. I've been in the Nevada clinic since 2018. I did spend a little time at the Regenexx clinic up in Des Moines, Iowa for 3.5 years before I came here. So we do want to jump into just talking about back pain. This is a common condition that costs a lot of money to deal with in direct and indirect cost. It affects many people. All of us have maybe at one point had some pain in their neck or low back, or at least know somebody that has, or has undergone treatment for it, whether that be physical therapy, medications, injections, or surgery. And there's significant burden and high cost for some of the surgical interventions. So some of these things carry extreme expense. Obviously, if we have insurance, and depending on out-of-pocket expenses, there can still be a significant out-of-pocket expense for patients. but just for the whole system in general, they can be quite expensive, and that's with everything goes smoothly. So it's important that, some of the things that we're going to talk about is trying to avoid some of the expense, trying to create better alternatives, and allow people to be in less pain without some of the invasiveness of surgery. It is important to understand some of the structural elements of the spine to get an idea of why we get pain, how we get pain, what can be involved, what can cause pain throughout our spine. Our spine is a bunch of bones and discs stacked up from the base of our skull down to our pelvis. So we have our bony elements, we have our cushion, our disc elements, we have the joint elements where one level connects to the next level beneath it. And then we have our nerve elements with our spinal cord and spinal nerve roots as they exit. We also have things that a lot of people don't think about. We have support structures that help keep the spine stable. And so we have our muscular tissue and we have our ligamentous tissue. So all of these individual structures, while they are individual, function together as functional units, and trouble in one area can affect and start to create problems in other areas. And so we use that philosophy when evaluating patients, which we'll talk more about. We don't like to look at the spine as just a disc or a joint, but these things can affect each other, and that is also how we treat the spine regarding our injection-based therapies that we perform, which again we'll talk more about. And so common sources of back pain, again, if you just look at what the structures are, those are the different things that can in some ways cause pain. So our bone through fractures, infection, those kind of things. Discs can cause pain through herniations or tears, inflammation, those kind of things. Joints can develop arthritis, just like your knee or your hip. Nerves can be compressed through growth, through disc herniations, through joint enlargement, through cyst formation, so many things, and chemical irritation. So those can be a cause of pain. The muscles can be injured, and the ligaments can be sprained or overloaded through degenerative processes. And so these are all the things that can in some way create back pain. So when trying to think about how to treat it, you have to kind of understand the constellation of things that could be causing the pain. And then you can start to develop treatment plans. And so before we get into the more specific things that we do at Regenexx, just to take a few seconds to look at things that you probably already know about. So there's going to be, sometimes lifestyle modifications regarding exercise, weight loss, core strengthening, improving flexibility. Those are things that most of us can, improve upon and work on to help improve the longevity and preservation of our spine. And then there's different medication treatments with our anti-inflammatories, steroid medications, pain medications, nerve medications, muscle relaxants, physical therapy, and chiropractic care, which, that's utilized a lot for spinal issues. It can be very effective. There's massage and acupuncture. There's the different injection-based treatments, which we'll talk a little bit about. And then the surgical options, which we hope to avoid. Now, just looking more specifically at some of these current treatment options, even simple things like taking an ibuprofen carries risk, right? While these are helpful for pain and inflammation for a lot of us, they are not without risk. All of the anti-inflammatory medications can create problems with prolonged use, death, stomach ulcers, increased cardiovascular events, high blood pressure, kidney dysfunction. So we have to kind of balance all of those things. And we all know about the opiates and the pain medication and all the effects that that can have on addiction, dependency, constipation, cognitive issues, and sometimes can be used in short bouts to be helpful, but they do carry risk, right? So it's all about when deciding on what to do about things is that balance of risk to benefit ratios. Treatment options that we incorporate a lot into our treatment plans and recommendations: physical therapy, obviously working on strength, flexibility, and biomechanics. Sometimes short-term use of brace can be helpful for flares. And then we get into the different injection-based modalities that are used a lot for spinal issues. So we start to look at these corticosteroids, or people hear of them as like cortisone injections or steroid injections. And these are essentially strong anti-inflammatory medications, and they can help with pain and inflammation associated with degeneration, inflammation. But they do carry risk. Again, they can increase blood sugars, weight gain, flushing, anxiety, and they are slightly toxic to our tissue. So they can be toxic to cartilage, so that's called chondrotoxicity. They can be toxic to tendons, bone health can be affected. And so these are things we need to take into consideration. So some of the common spinal injections that cortisone is used are epidural injections. And these are for patients that have back pain or irritated nerves from some source. They're performed many times a year, so greater than 9 million performed per year in the United States. And the doses we use are supraphysiologic, so which is what kind of drives some of their toxic effect on the body, especially with repeat exposure. So for example, even exposure to one epidural steroid injection increases the risk of an osteoporotic fracture by about 30% in women. And these tend to be like postmenopausal women. So even one exposure can have an increased risk for complication. You can also use these for your joints if there's arthritic change or inflammation. And again, steroid medications are potentially toxic to your cartilage and can actually advance degenerative arthritic changes. There's other pain procedures in the spine that are interventional, meaning injection-based and non-surgical. And one of them is called radiofrequency ablations. So your joints in your spine are innervated by little nerve roots. And so you can use a needle with a wire to heat up and burn and destroy those nerve roots, which can help essentially reduce pain. However, part of this nerve root extends into your deep back muscles, your multifidus. And so you temporarily essentially paralyze that muscle, which is a stabilizer of the spine. And these nerve roots grow back, so it tends to be kind of a recurrent treatment process. And I've done these procedures, and they can be effective for pain control. But if we can utilize things that are non-destructive, don't take away nerve input and innervation to muscle stabilizers, then that's a better situation. And then obviously surgeries, we all hear about spine surgeries. It's best to avoid them when possible, because people can continue to have pain despite surgery, right? I mean, failed back surgery can be as high as almost 50%. That means people that underwent surgery that still have chronic pain. Even after surgery, the disc can re-herniate. People can still have chronic pain. A lot of people might need additional surgery. Obviously, infection, nerve injuries, blood clots, risk of anesthesia, all of that stuff are things to take into consideration. I heard a surgeon, he's a spine surgeon, he said the reason that we call it back surgery is because we will see you back at some point for more surgery. So if you can try to avoid or delay that as long as possible, that's definitely the best scenario. Sometimes it's the right choice and the only choice. But if you happen to be in that situation where there are other alternatives, it's worth exploring those options. And so when we get to what we do in our approach and our philosophy to treating the spine and all orthopedic conditions, is we take the approach at what can we do to help preserve the tissue, orthopedic tissue, how can we keep it there? And so that's our goal. And so our goal is to use essentially less invasive procedures to help prevent the need for more invasive procedures like surgery when possible. So we want to repair and stabilize the tissues of our spine and our other orthopedic joints. And we just basically want to take advantage of our natural healing mechanisms that allow us to kind of go through life and repair tissues. Now, some tissues do break down through injury or overload or degeneration or other genetic type influence. And so we want to find ways to help enhance some of those tissues naturally. And so Regenexx has been around for nearly 20 years. So Regenexx started in 2005 in Colorado, and it started with basically wanting to innovate in the lab. It started with a couple years of clinical research, teaming up with Colorado State University. We've always tracked patient outcomes in our registry. Currently, we're tracking 70,000 total patients. I think spines account for maybe 18 or 19,000 of them. We use data to guide our treatment decisions. And so we'll learn that as part of the evaluation process, we have a candidacy grading based on some of the things we find out within our new patient evaluations. And then as an organization, we're always publishing research on some of our data, on our randomized controlled studies, and trying to use that for patient and just provider education. And so we do have a large network. This is one clinic that's part of the Regenexx network, but we have clinics all over the country and some around the world. Again, to date, as far as our registry goes, there's people have been, close to 200,000 patients. We're actually at about 70,000 patients in our registry now, and about 18 or 19,000 within our spinal condition. And so some of these numbers have actually increased since last year when I originally made this presentation. And all of this, again, is just the natural evolution of medicine, moving forward from more invasive to less invasive, utilizing technology and our understanding of how we can improve tissues without doing surgery. So as I said, natural evolution, again, everything we do is needle-based. We're using healing factors. So what we specifically do is we're isolating cells, growth factors, stem cells, these types of things from patients' bodies, elevating the concentration of them within our lab, and then using needle-based, precise needle-based, injection-based therapies to help deliver these cells into areas with degeneration, inflammation, wear and tear, tears, arthritic change, with the goal of helping to preserve, improve that tissue, reduce inflammation, and kind of get that tissue back to a healthy state. When you can do that, then symptoms can be improved significantly. And so we kind of take, like I said, a global picture about what's going on with the structure, not just the disc itself, but how that affects the rest of the tissues around it, and what downstream effects it can have on the body. Spinal issues, specifically nerve problems, can affect either the upper extremities or the lower extremities. So you can have foot pain, ankle pain, knee pain, hip pain that comes from your back. And so you have to have a good evaluation to be able to understand the symptoms and the constellation of things that they're causing downstream. And we have to remember that the spine is a functional unit and not individual components. That's important because that's how our approach to treatment and recommendations. And so when we get into specifically what types of things are we using to treat the spine, And we'll talk more about these in detail, but we use a solution called PRP, which we'll talk about, platelet lysate, platelet poor plasma, bone marrow concentrate, which contains mesenchymal stem cells. And so these are all cellular based solutions that we can isolate from patients' bodies in reservoirs that house these different types of cells and growth factors, take advantage of their natural mechanisms of healing, and then deliver them precisely into the areas of the spine, or as I mentioned, other joints that we treat, to help improve the overall either local chemical environment, help stimulate tissue repair in those areas. And so we utilize things from the blood. We can extract cells from different tissues, including bone marrow, and we can isolate these cells that we want to use and use them in areas that are having some trouble with repair and have pain and degeneration. One of the common cells that we use is the platelet. This is found in the blood. When you isolate platelets and concentrate them, we call that PRP, platelet-rich plasma. Platelets are important because they're the activators of healing. So when you injure yourself, platelets help control bleeding. They release these different growth factors to help stimulate different types of healing responses, from cell growth and repair to blood vessel innervation, to collagen production. And so we can take advantage of that property, and we tend to use these isolated concentrated platelets for mild to moderate arthritis, ligament, muscle sprains and strains, disc pain, depending on the severity, nerve irritation, those kind of things. So it's a common thing we use in the spine. We also can specifically extract those growth factors that I mentioned, which are housed inside platelets, and this is called platelet lysate. When you use the growth factors directly, we tend to use those around nerve spaces. So like a sciatica or a pinched nerve, if that nerve is inflamed, then we can use this around the nerves. It's a healthier, more natural option than a steroid injection, can last longer and have more potential benefit than a steroid injection as well in the nerve space, epidural space. We can use the plasma, which is void of platelets, to help stimulate muscle stem cells called satellite cells to help with repair. And there's multiple studies showing that that can improve muscular tissue and atrophy. An important thing about the muscle stabilizers is people with chronic back pain tend to have atrophy of their deep muscle stabilizers called the multifidus. And so platelet poor plasma, there's a couple studies showing that it can improve some of that. The other thing we use bone marrow concentrate, which contains mesenchymal stem cells. And so stem cell therapies are what people hear a lot about. These are cells specifically concentrated from the bone marrow. Stem cells are important because they have a lot of potential at what they can help improve. They can work by improving the chemical environment, similar to platelets and growth factors, but they can also be transformed into different cell lines based on the environment that they're in. And so they can work by orchestrating healing, but then also becoming a part of that environment. And we can use these for disc injuries, painful discs, and more moderate to severe arthritic change in the spine. And so just as a summary, some of the injection-based modalities that we use, which are under this umbrella called orthobiologics. So biologic cells that come from our biology, our bodies, and orthopedic, things that we use for orthopedic problems. PRP, again, for more mild to moderate arthritis, inflammation, ligament injuries, mild disc problems. Platelet lysate, we use these around nerves. Platelet poor plasma, we use those for muscle treatment. And bone marrow concentrate and mesenchymal stem cells, we use for the more moderate to severe conditions. And so just our spectrum of what we offer everything we can do in the US is here. We do have a clinic in the Cayman Islands that's allowed to grow out people's stem cells, which we are not allowed to do in the US. And we could talk about that more if people have questions on it. But we can use platelet and growth factors, we can use PRP, or we can use bone marrow concentrate stem cells for these different spinal conditions. And so when we look at different data that we use to show benefit compared to, say, more traditional treatment, utilizing platelet lysate for irritated pinched nerves was more successful than steroid injections. So the overall functional and pain improvement scores were significantly better compared to the steroid group. And it took less treatments to get better. So that's important. We do have some FDA approval trials going in phase 2 for the growing out of the stem cells for disc degeneration. So hopefully we'll get that approved in time. That'll be helpful for allowing more access to these types of therapies. There's other studies out there looking at treating disc pain with bone marrow stem cells. Dr. Patin, 81% of people avoided surgery. And this study actually was carried out for 5 years. And the overall reduction in pain was 70%. So people responded pretty well. Another spine disc study with platelet-rich plasma, so the platelet group. It was a randomized study, and at 1 year, people that were treated with PRP had maintained their benefits, showing significant improvement in pain and function. Our approach with treating the functional spinal unit at 2-year follow-up, people were still having significant clinical improvement in their overall pain and function related to cervical spine degeneration and pain. Other disc studies, let me see, I think I went backwards. These are all of the other spine studies that we've published on for cervical spine, for lumbar spine disc degeneration, epidural treatment with platelet lysates, upper cervical spine instability, and discal injections in the low back. We do have a big registry, as I mentioned, that tracks patient outcomes over time, and it's published on our website. Now, this is just a big pot of all patients into one big group. So when we have consultations, which we're going to talk about, we can be more specific based on your specific situation and findings on imaging as far as the candidacy and success. Our process is such that we do a comprehensive evaluation, tends to be about an hour long. We review all of your medical history, and we spend a lot of time assessing your MRI and walking through what's going on structurally. We have to assess physical exam to assess if your back is affecting other parts of your body, and that helps us create a discussion on what the options are. We tend to discuss all options, including some of the Regenexx specific options. And then we talk about your candidacy. Are you a good responder, a moderate, or a low responder candidate based on your findings? And then we discuss what that means regarding success rates. And every part of the body is a little bit different. And so, people will ask, well, how successful is it? Well, it just depends. Is it your knee or your hip or your back? And then how bad is your back? Is it 1 level? Is it 5 levels? Do you have severe stenosis or a small disc bulge? All of these things will have different levels of success. So for example, taking patients, sometimes we'll only use platelet lysate. So if somebody just has an isolated disc herniation and everything else looks good, we might use this, and they might be a high responder. So they might have an 85 to 90% chance of success, may need 1 or 2 treatments, but get good long-term improvement. Someone else with that undergoes that process, the day looks like this. So they come in, they have to get a blood draw, we have to process that blood in our manual processing lab. And this is important that we have the ability to create all of these different products in the lab. And we have the customization and the flexibility with our lab to create different concentrations, types of products based on your age, injury severity, location, and tissue type. So your disc will need something different than your nerve space or your joint or your muscle. And so being able to create these different products helps us treat people with a more customized treatment plan. And then with injection, we always use X-ray and ultrasound guidance, depending on what structure we're treating, to ensure that you're getting these cells to the proper locations. If you have more severe changes and have not just disc, but other problems like joint arthritis, then we tend to treat all of those structures in one big setting. And so, again, we're treating the functional unit of the spine. And so we can use PRP for the joints, we'll use platelet lysate for the nerve irritation, and we'll use the platelet-poor plasma for the muscles. The process is the same, but our lab will be able to create these different products to take care of those additional problems. And then if you have a lot of different issues, this is kind of showing that more comprehensive approach where we're treating the nerve space, we're treating the joint space, we're treating the ligaments, and then we're also treating the muscles. So here's a needle injecting the multifidus with the platelet-poor plasma, trying to improve pain coming from those locations. And then sometimes people have where they have to treat everything, including the disc. And so we can use a combination of stem cells plus PRP for the disc, stem cells plus PRP for the joints, ligaments, plasma for the muscles, and the platelet lysate for the nerve irritation. The process is the same outside the bone marrow aspiration. It takes about 30 to 40 minutes to isolate the bone marrow and get the cells we need. The processing time can take a few hours to count and isolate the cells. You can use sedation, and then we still use our flexible lab platform and the injection on the same day. People get concerned about us talking about bone marrow aspiration for stem cells. This is very well tolerated. It's been done many, many times. There's large studies looking at safety. And so people can use sedation like a twilight anesthesia. We use a lot of local anesthesia. People do very well. And again, it takes about 30 minutes to get the bone marrow and about a few hours to isolate the cells. And so that type of procedure would look like this: the bone marrow aspiration. After the processing, later that day, we would treat the nerves, the joints, the ligaments, inject the disc, and then also inject those muscles again. This is what we call a full functional unit treatment, where you're treating disc, joint, nerve, ligaments, and muscles. And again, that's what we use a lot for degenerative discs, to help improve stability, overload, irritation, and to help strengthen the tissue. And so just a basic post-procedure kind of treatment of what we see. People do get a few days of increased pain and stiffness. If you're treating a disc, it can be up to 2 weeks. Most people will need some sort of physical therapy. Some people get a brace. Some people will need some pain medications post-injection. We will have people modify their activity over the first couple of weeks and then return to full activity as their symptoms allow. And then we have follow-ups multiple times after the treatment to ensure people are getting better. There's always some people that need more than one treatment. Depending on the starting severity, we can see up to 30% of people might need more than one treatment as you let time go on. But we never schedule a series, or we rarely schedule a series of injections without first evaluating the response. Most people won't need to do a series, and can get good outcomes with one treatment, but there are some people that will need more than one treatment to get sustained benefit. So just looking at different things that have shown improvement, so big disc herniations receding, disc tears filling in, disc herniations getting smaller, even some bony injuries showing improvement, which I don't have here. So with all of that, I try to get through that. And just to give a brief overview of how we address the spine, going through some of the more traditional options and some of the risks and benefits of even medications, risks and benefits of cortisone injections and burning nerves. Obviously, spine surgery carries significant risk with high failure rates, high complication rates. While we do send people off for surgery sometimes, it's always good to explore all options before undergoing the knife, as long as it makes sense regarding pain and your neurologic status, since your spine does house all of your nerves. So with that, let me open it up to questions and see if anybody has questions for me that we can walk through regarding treatment that we provide or other options, typical follow-up or treatment schedules. If anybody has questions, just write them in the Q&A section or the chat section. Okay, some people will ask about like age, if that plays a huge role on outcome. We haven't seen that it plays that big of a role. Even older patients have functional platelets. Now they might be a little more sluggish than they used to be. We counterbalance that sluggishness through elevating the concentration. So because we have the flexible lab platform, we can get higher concentrations of the platelets and growth factors by just drawing a little more blood and kind of pushing all of them into a smaller volume. And that can kind of compete with any intrinsic deficiencies of function. But we haven't seen age play a huge role. There are, again, certain structural things that might not respond as well, which could include, like, if you have a bone spur pinching the nerve, it's not going to eat away at the bone spur. One thing we don't see happen is if you've lost your disc height, it doesn't regrow the disc. Our goal is to help strengthen and stabilize it so it preserves what you have, which can go a long way with symptoms, but it doesn't regrow a completely degenerative disc. And then the amount of narrowing around the nerve sac or nerve space can influence even if we recommend an injection. So we see people with severe stenosis, which means narrowing around your spinal cord or your nerve roots. And if we can't get a needle there, or it's too risky to put a needle plus extra fluid to take up more space temporarily, then sometimes it's just not the right option, and we make those recommendations. Our goal is to make people informed of their condition, understand what's going on and why they feel what they feel, and then to have a very concrete understanding of all treatment options, including your traditional and Regenexx options and surgical options. And then people will use that information to make the decision that's best for them. But they need to be informed about what those options are in order to make that decision. And so that's kind of our approach to it. The risks are really no different than other types of injections. The addition of stem cells and platelets don't add additional risk. The risk comes from poking needles into the spine. So that's really where it is, whether you're poking a needle into the spine and you're going to inject saline, there's still risk related to the needle being placed into the body. So really no additional risk than that. So people will ask that question as well. So some questions about what is the success rates, how many are success to date, what are complications, and what are risks. So again, as I was saying, success rates are going to vary depending on the condition, right? If you have an isolated disc herniation with preserved disc height, less than a 5 millimeter disc herniation, no significant joint arthritis, only mild stenosis, then success rates can be in the mid 80s to 90% of patients getting significant improvement. Some of those patients might need a second treatment to get sustained benefit, but most people would do good with 1 to 2 treatments. If you have complete disc height loss at 5 levels, severe stenosis, bone-on-bone arthritis, then the success rates are going to be significantly lower. You might not even be considered a candidate in that situation. So it's variable depending on the structural findings and the patient, right? If you look at just our registry and you take everybody that's been treated, some of them are good candidates, some of them are poor candidates, and you just look at the overall average reduction in pain, it's about 60% reduction in pain and improvement in function. So that's taking all comers regardless of their candidacy, and you average out the overall response rates. That's what people on average get as an improvement. Again, some people are 100%, some of those people might be 0%, but when averaged, it would be about a 60%. But again, to be more specific, at your specific chance of success, it would need to be determined based on your structural problem. Disc, joint, nerve space, muscles, those kind of things. How many levels are being affected? And then we can say, well, you have an 85% chance of success, a 60, a 30, or anywhere in between based on your specific findings. Complications that I mentioned are very similar to other injections. You can have soreness, bleeding, bruising. Obviously, if your needle poked a nerve, you could have nerve injury. Anytime you put a needle inside someone's disc, there is a risk of disc infection, regardless of what you're injecting, whether that's cortisone, whether that's saline, whether that's contrast, or whether that's stem cells. There's about a 1 in 1,000 to a 1 in 10,000 risk of a disc-related injection or infection as a result of an injection. Now, we did some studies on different preparations of PRP, which can help reduce that risk. So that's what we utilize, so it can reduce the overall risk. But those are some of the more common things. Everybody that gets a spine treatment does have a couple of days of soreness, which is expected. And as I said, overall, right now we're tracking about close to 20,000 spine patients. Just spine patients, I've probably treated a couple thousand patients. I haven't had any major complications. Obviously, we get people that get sore, we get people that get a little flared up if they had certain conditions. So, again, a lot of it gets down to what's going on structurally. Another question was, can you tell based on imaging how many treatments a person should get or recommend? How old should the MRI be? So we have, based on the imaging, we'll give people our best guess for how many injections it may take. If you look at spine treatment in general, I would say that most people can get good improvement with 1 treatment. I would say about a third of the patients will end up needing 2 treatments to get sustained benefit, and less than 10% of people will need more than 2 treatments. We can't predict precisely who's going to need 1 versus 3. but we can get a sense based on how bad the structure is. Having said that, one of the worst spines I ever treated got better with one treatment, and it's been like 7 years, and he's still doing well. And then some minor or I would say more mild changes have needed a couple of treatments to get benefit. So it's not a universal kind of phenomenon that you can predict across all people, because there's many variables. There's more than just the structure. We don't know how to measure the variables yet, because of the variations we see, but we get a general sense. And we like the MRI to be within 12 months, unless there's recent change. So say you had an MRI 6 months ago, but now you have new weakness on a side you didn't have it, then we would recommend an updated MRI. And we can order MRIs and those kind of things if we need to. If people have imaging and they want to see, is it even worthwhile doing a consultation? Then people can send in their MRIs and I can review them to see if is it worthwhile coming in or having a more formal consultation to go over all the options. As I said, our consultations are very comprehensive, and so we like to evaluate, assess, educate, and then people will leave, even if this is not the right choice, having a better understanding of what's going on, have an understanding of all options available, and then they'll be able to make a good determination. I put this up to be able to reach out to our scheduling team. We will have to update this, but I would definitely use this number to call our call center to schedule. If anybody was interested in getting their MRIs to me, talking more, getting more educated, getting in for a consultation. Consultations, if you have insurance, we are contracted with most insurances for consultations that can be billed through insurance. A lot of the PRP and stem cell based spine treatments are not covered by any insurance outside some of the corporations that cover Regenexx procedures. So we have more than 2,000 companies that cover our procedures for their employees. But like Medicare and United and Blue Cross don't cover any regenerative based therapy for spine conditions at this point. We're hoping to change that with some of the coverage that we do have and showing the benefits of allowing access to these types of cares, this type of care and treatment. Costs are mainly out of pocket for patients, and they can be anywhere from maybe $1,200 to $6,000. You know, it depends on what's going on and what we're treating and how many levels and how many structures and sedation or no sedation. So again, all of that gets discussed very transparently when people are here, when we're trying to go through their specific problem, their condition, their options, those kind of things. So I don't see any more questions at this moment. Again, the call center is here. Feel free to reach out. If you have more questions, feel free to call and schedule a consultation just to get more specific information about your condition and how these treatments may or may not help. I'll just give it one more minute to see if anybody else asks questions. And I guess in the meantime, I appreciate your time spending an hour with me. It's already been an hour, and listening to me ramble. Sometimes these webinars are hard because you're just looking at a screen, not really being able to engage too much. So I appreciate your time. I don't see any more questions, so I'll let you guys get back to your evening. Again, feel free to reach out, and I hope we can, let me see, full functional treatment. Is that a package? So for a full functional treatment, you mentioned, is that a package treatment? Well, that's just part of the treatment. So say you have a degenerative process in the spine, the treatment will involve treating all of those additional structures, right? So we'll be treating your joints, ligaments, muscles. And so that's kind of part of that full treatment session. as opposed to the more traditional pain management approach is, let's only inject the nerve space. Let's see how you do. Oh, you only got partial benefit. Let's try it one more time. Okay, well, that only helped partially again. Let's do the joints. Oh, that kind of helped. Well, let's do it again. Okay, well, now let's check the disc. Well, that kind of helps. Now so it's more trying to treat everything globally that's a part of your problem. And so, so yeah, that's part of that session of treatment. And then that can be obviously combined with physical therapy, which we don't have internally. So we have to refer people out for that. Obviously, that can go through insurance and stuff. We do have other modalities here, like we have a pain laser, which helps with recovery and swelling. And those are just like separate things that can be kind of included as part of a treatment, but additionally are separate costs, but at a reduced cost when combined with treatment. It says, I know we were talking about back problems, but can you offer anything for cartilage, specifically hip, bone on bone? So we do treat a lot of arthritic joints, hip, knee, shoulders. I will say that hip joints are the least responsive joint. If you're truly bone on bone, we would recommend a hip replacement because success rates with stem cells in a true bone on bone joint are less than 30% of patients get benefit. So we would say that in that setting, it's not the most successful for true bone on bone. For knees and shoulders, for bone on bone, we still see a good percentage of patients get better with pain and function, even for years. But hip joints tend to be the least responsive joint. So it's not the most successful joint. Usually, if I get an MRI that has severe bone on bone and it's a hip, I usually just tell people they're a very poor candidate, that the chance of improvement is 30% or less. And if it does help, it's probably going to last less than a year. So, you know, that's where we are with the bone on bone hips. If it's more moderate arthritis, like maybe 50% joint space loss, then there's still good options for that condition. Or we'll still see good, 70, 80% of patients get better, utilizing typically more of the stem cell approach. So that's, hopefully that answers your question. Somebody asked about, are we going to do a seminar for shoulders? Yeah, I do need to create one. We do have like a general overview. We have our back and our knee seminar, but we'll probably do one for shoulder. Full thickness rotator cuff tears. We can treat and have some success with full thickness tears, but there can't be a lot of retraction. So it can be full thickness, but if there's a huge gap beyond a centimeter or so, then we're not going to recommend a procedure. We would recommend surgery in that situation. So if you have a full thickness retracted supraspinatus tear of more than a centimeter, then we're going to recommend surgery. Now, some people that can't do surgery, we've treated to help control inflammation and to treat other support structures that are still intact. But our expectation would not be to heal a largely retracted rotator cuff tear. So there are going to be some limitations with the success rates depending on the amount of gap. Great. I appreciate the questions, guys. If there's more of that, obviously you can email us or give us a call or come see me in clinic and we can try to address all those questions. We can see people for multiple conditions at one time. We do have ultrasound in the clinic. We do not have our own MRI, but we can send people out and get that stuff ordered. So again, I appreciate your evening. I'll let you guys get back to it. And again, I look forward to seeing you guys in clinic if you guys choose to do so. Thank you.